So there's going to be some different discussions, obviously, when you're talking about selecting treatment. Number one, it's important about knowing what stage the patient is. In that setting, we only have limited therapies in the early stage setting. Whereas if you're talking about metastatic disease, that's a little bit different. There we're utilizing more molecular marker analysis as well as chemotherapy in conjunction. We usually give the two together regarding biologic agents, and the choice of biologic agents is dependent upon what the mutation analysis shows. So there are two very different discussions, I would say. It just matters based upon what your goals of treatment are and what your stage of disease is.
If you've been told that you have metastatic colon cancer, and they've also looked and said there can't be surgery, the hardest thing you're going to hear, the worst news we have, is that we can't fix you. We can help you. We can extend your survival. We can keep you alive longer with treatments. But today, we don't have medicines that are going to make the cancer go away. All right? So what we're going to do is we're going to use the tools that we have. We have chemotherapy, we have radiation, we have newfangled liver-directed therapies, new research trials and the like. And so we're going to use all of those tools. Think of them as chess pieces. And we're going to move some now, we're going to save some for later. We might move one more than once. We might move it even more than twice. And we're going to play a smart chess game that balances the toxicity and side effects versus the control of the cancer. Priority, control the cancer. Sometimes we can do that with one or two drugs. Sometimes we need to have our foot on the pedal a little harder and use more medicines. So your physician's going to make a recommendation based on that. Often, we put our foot on the pedal a little hard at the beginning. We use multiple medicines, but then we let up. If we're moving pretty good and the cancer's under control, we lighten up in what we call maintenance therapy. And then depending on how long that's under good control, we put our foot on the pedal again. We bring a new chess piece to the table. We might need gene testing to figure out what's an option. At every step of the way, there often is a clinical trial. Your physician might offer you a choice between, say, a standard medicine and a new medicine, or might just offer you a new medicine instead of the traditional medicine. And so you should listen out for those every chance you get, because in a way, those are extra chess pieces that you're getting on the board. You still have the other chess pieces, but you get a new one to see if it helps. And the idea is to keep your quality of life as high as we can. Functioning, working, living, enjoying life, minimizing your toxicity, keep that cancer under control, keep you on the planet moving around until as long as we can, or until we can change what I just told you about your cancer and find something to fix it.
I would say the most important thing to keep in mind for a patient with metastatic disease, which means stage 4 disease, the most important thing to keep in mind is that you need to have multidisciplinary discussion. So obviously the medical oncologist is your most important person in regards to the base of your care, really forming the foundation of your care. But if there's any potential for surgical resection, that should be discussed up front, and that you should have your medical oncologist try to speak to one of his colleagues, whether it be surgical oncology, interventional radiology, radiation oncology. It just depends upon what you're discussing, whether it be the actual tumor itself, if it's still in the colon or the rectum, or is it about the site of metastatic disease. I mean, these are very